You're listening to All the Pieces, a podcast created to keep you informed and to highlight the great things we have going on at Mosaic and in the communities we serve. Let's take a look at all the amazing pieces here at Mosaic that together make us great. Now here's your host, Chief Quality Officer, Dr. Curran Mohan.
Hello and welcome to another episode of All the Pieces podcast. I'm your host, Dr. Mohan, Chief Quality Officer and Hospitalist. Today, we'll be discussing workforce violence. As a continuation of our discussion with Derek Kahns and Sarah Juarez, along with Lainey Taylor last time, today we will talk to frontline caregivers. Workforce violence has been an issue in America for a long time, but when it affects healthcare workers, it hits close to home. Today, I have two frontline caregivers, Stacy Bratton and Abby Herman, who will share their stories. But before we get into our discussion, I would like them to introduce themselves. Stacy?
My name is Stacy Bratton. I'm one of the associate directors for the emergency department.
My name is Abby Herman. I'm one of the registered nurses in the emergency department.
Excellent. Thank you for being with us today. Today we'll discuss something that happened to Abby. And Stacy, I believe you were present with other leaders. And we're going to discuss what happened in that day and what led up to that moment and what happened after that. But before we go into that, I do want to mention that national statistics are alarming. 40% of nurses have reported that there has been some sort of abuse, whether physical, verbal, or other, in their work environment on a consistent basis. This is a trend that is not slowing down, and we're doing our best to get a handle around it. And nobody has a perfect formula. But a big part of that discussion is having moments like these, where we fully discuss how is it affecting your workplace, how is it affecting your job, and to be honest, how it is affecting your calling. So Abby, I know this is sort of a personal thing for you, and I want to first of all thank you for being here with us. Can you describe to us this incident and what was happening that day?
Yeah, my friend brought in a patient on the ambulance, and she was having hallucinations and paranoia. So she was actually in our little hallway in between the two sides that we call the chair rooms, that are just kind of some rooms that are a little bit smaller, away from all the hustle and bustle of all the carts in the department kind of going by to CT scans and going up to the floor. So I stepped over to take care of her, and we started out there, and I actually had police in the room next as well with another patient. So started with those two patients, and I kind of just sat charting right there so I could be very present one-on-one and kind of just document everything I was seeing with behavior, mannerisms, everything like that. To get her to go from one room to the other, I wish I could say I was exaggerating, and that it took 55 minutes to over an hour.
Wow.
We would get from one place and stop, and she would have to fight with her hallucinations, and they were mostly auditory for her. So listening to probably all the alarms in the ER, listening to me try to coax her into walking willingly to this room, trying to listen to me, convince her that I am here to help her, when I don't know what her auditory hallucinations are telling her. Mm-hmm. The paranoia was just making her very vocal, verbal. She was very hyperactive with her mannerisms and her hands. I talk with my hands as it is, but she was yelling with her hands, we can say.
All caps lock.
All caps lock. Took a very long time to get her to the room, and she willingly took meds in 2 different doses. And that still wasn't enough to overcome her hallucinations. And before the incident, I actually sat at the end of the hallway charting just because I knew that she was very emotionally labile, and I just was waiting for when it would explode again.
At any point, did you suspect that this person might be violent?
I'd kind of known that she had the potential to escalate, but I also know that meth does not help. That just increases the risk of the escalation based on the psychosis that it induces with these patients. So I stayed back there charting just because I knew there was a risk. I had her hooked up to a monitor because I had given her medications And anytime I do that, I like to make sure that my patient's vital signs are still stable. In those mental health rooms, they don't have any monitors back there just for the risk of some patients may try to harm themselves with the monitors, the cords. So I had a little roll-around monitor with a pulse oximeter so I could monitor heart rate, oxygen saturation, and then I had a blood pressure cuff. I don't think I ever got a blood pressure because she refused, but I was able to have a pulse oximeter. And a few times I'd have to go back there, I'd hear her screaming. She was very upset that the medications I was giving were not helping with her auditory hallucinations. She said, I still hear the voices, and she was kind of blaming me, like, why aren't they stopping? Why didn't you make them stop? And it was so hard to redirect and refocus with the tangible thoughts and the hallucinations. So security was there to help, and they also kind of recognized that having a conversation with her was very difficult because she couldn't make a concrete thought. So a nurse partner had the other room next to her and was back there with his patient, getting to know them, talking with them, and all I heard was her scream, and she had come out of the bed at the end of the bed and was very angry that her hallucinations had not stopped. She was still hearing the voices. So she took the pulse ox off, and I wish I could reiterate this. I wish I had one to like demonstrate, but she swung it like a lasso and chucked it at my head, so I ducked at that moment. Malachi and I were both there, and we had gloves on, so she was at the end of the bed standing, and the rails were up. So we took the opportunity to do CPI technique. Let's put her in a high-level hold right now. She's throwing with intent to injure. There's another patient here. We need to gain control of the situation. So we put her in a high-level hold and laid her on the bed. Malachi with his right hand was on her left, so she's laying back. I always have to do this, like mirror. So his right hand was on her left. My left hand was on her right, and we put her in a high-level hold on the bed, and she reached over and grabbed my finger with her teeth and bit me. I'm very thankful I had a metal wrap ring on. So it was my pointer finger. I had a metal wrap ring. I don't wear it anymore because it has a tooth mark in it. So I still keep it. The saying on the ring is probably not very appropriate, but it's funny. I'm a little, we call it punchy or Western. I rodeo, I have horses. So my wrap ring said shittle buff. So shittle buff, I had a metal wrap ring, and when she bit me, her tooth hit that ring. And those wrap rings, when you create pressure, they just get tight. So I'm very lucky that I did not have any breakage of skin. I did have a lot of some swelling and redness because of the constriction. At that point, my glove had ripped, and I wasn't able to see at that point that if she had bit me, if she had broke skin. Because a huge concern for me was this person is somebody that has admitted to methamphetamine abuse and admitted to having injection site infections. I am going to have to go through a lot of blood work if I have an actual puncture, like breakage of skin. A lot of staff had come back at that time. The ER doctor was there and evaluated me right at the bedside. He grabbed my finger, and Dr. Tyler Brown grabbed my finger and looked at it, and he's like, "You're good." And then later on, he looked at it closer when the adrenaline and the high stress situation kind of calmed down. He looked at it again. I'm sure because I probably grabbed it and made it red. Just like natural instinct. Natural instinct was to pull my hand back, and that's when my glove ripped. Security came back and helped assist holding the patient, and the ER provider actually gave the injections for me. She was discharged. Police was obviously there with my other patient and saw the breakdown of the encounter that I had with this patient and how much I tried to reason with her when there was no reasoning. There wasn't really going to be reasoning. So they were already in the department, so making a police report was fairly easy. just because they were easily accessible. So just actually 2 weeks ago, I went back and checked, and she was charged and pled guilty. And I think this was in February, so it might have been before the Missouri statute of the special victims. I don't know when that became into play, like how they could be charged on assault on a nurse's security or that were special victims. So I think she just got an assault charge and she pled guilty and she had to pay a fine, which, no, it's not jail time. It's not what we may think is reasonable for assaulting one of us. But when I think about it, like, that fine, that's a hefty amount. Like, she probably, like, that was a lesson for her. I got an email from the legal team, and I really appreciated the support I got from them. It said directly in their email, like, this is your court date. We are supportive of you. We are very happy that you are going through and standing up for yourself and saying no to workplace violence, and we're glad that you press charges, and we're here to support you in any way we need. So it was nice to see it from a higher standpoint, like getting that support.
You can deliver good care if you don't feel safe.
Yeah.
This is not just a personal code of conduct, but an organizational code of conduct. When you have patients like these, Abby, and I mean, it can be a random mixed bag for certain days, do you normally share that with your leaders? Like, I'm in an environment that's going to be high stressful or high elopement risk or high psychotic patient risk? Or is it sort of understood that that's, if you're in that area, you're in that area, and it's going to be what it is?
We have blue zone and purple zone. I'll let my nurse partners know, be like, hey, this is what's going on with this patient. And they'll pick up what I say my slack. If I'm with a patient one-on-one, they know where I'm going to be, and they know that they're going to have to help me out by just taking care of the other patients that are coming in. They may not be able to help me directly by being back there with me with a mental health patient or with any other patient that I have that I'm with for more time. But they help me in so many other ways, just by keeping the flow of the department going and checking on my other patients, rounding on my other patients for me.
So like a team of teams in a way, so they understand where the needs are and they address it to help the flow of the people through the system. It just happens to be on this day you ended up getting the short end of the stick, or a high adrenaline environment for sure.
High adrenaline for sure.
I'm going to shift gears a little bit for a second and get Stacy's input on this. Stacy, you're a leader in the department. You have seen both from the caregiving front line, bedside, to also how the sausage is made, if you will, on the back end of leadership. What do you think has been the take of the ER nurses and techs with patients like these in the past and currently?
So personally, I've been in the emergency department for a little over 3 years. So one of the awakenings that I had when I came to the department was the level, the volume of violence that was a common occurrence in the emergency department. So I'll say that the amount was educational for me. I feel like our staff it's an expectation that those cases are going to be coming through the emergency department and on a pretty routine basis. We know that potential for violence or just being out of control or just being acute is just part of the job. I mean,
Nature of the beast.
It really is for the emergency department. We just have that knowledge that patients can come in, and what may be docile one moment can be at a level that Abby described, that is all hands and all caps, and there may be very little transition between those two.
Right. The reaction time has to be lightning fast.
It does.
So, when you hear a story like Abby's, where there is an instance like that, as a leader, what is your first role in this type of situation? How would you address this environment, or how would you address the caregiver if you were on that day?
So one of the things, if I'm present during the time, I would want to go to the location or be in a position where I could view the interaction. My office is at a point where I have easy access to caregivers. Caregivers have easy access to me. And of course, everyone hears the overhead pages.
Yeah.
But often, well before the overhead pages, we can hear escalations beginning. So often when we hear them, we'll go. Even if we are not directly participating in it, we want to go and kind of see what the situation is. Of course, the associate directors not being totally frontline, of course, we have to have that advanced CPI training as well. So if we had to step in and help, we can do that. So first, I would want to just go and witness and see what the situation is, and make sure we have the help that we need there, that everybody's responding appropriately, and essentially just trying to assess the situation, always wanting to make sure that we are trying to keep that patient safe in light of their behavior at that moment.
Right. It's always patient safety, caregiver safety at the paramount. In your opinion, and this question for either one of you, has the advanced CPI training been useful?
I would say to a certain degree. I think Abby could probably speak more on it than me, but I think to some degree it's better than nothing to have this training, but there are times when the patients are at a certain level. It's not always effective, in my opinion. It's not always effective.
And that's a tough one when you have to do mock combat, so to say. The utility of CPI, in my experience, has been pattern recognition and how to de-escalate verbally on a situation before it gets to the boiling point. Obviously, fight or flight kicks in. You know, it's hard to remember your CPI training when you're getting your finger bit, you know. But the recognition of it is a big part of it as well. How do you feel about the security officers here, and how is the response to that aspect when things do boil over, you know?
If I have a patient that I'm worried about a flight risk with, I will give them a call and give them a heads up, because they've got numerous cameras up at triage in the office. They can keep a closer eye on them for me and be more readily available. They could even respond to that patient trying to leave before I even know that they're gone from their room.
Our security team is amazing, and they have been very responsive, not just with situations that are high stressful, but also for med teams and code blues, and just an overall presence of safety. Switching gears again, Stacy, when an incident like this happens, you know, you mentioned that you obviously go in there to assess it when it's happening in real time. Can you describe your process after the incidents happened, and what do you do as a leader to help the caregiver walk through the next steps?
So, seeing first how it's going to hopefully de-escalate and what the process was for making sure that's done, from a leadership standpoint, making sure as far as process that we're following all the steps in the process. We will go around, depending on the injury of our caregiver, following up with the caregiver if there is injury, making sure that they have getting the medical attention that they need, that they're following up with employee health, and then on the back end, making sure that the proper forms are being filled out. So from a leadership standpoint, I'm making sure those are done, and then if there's appointments, just making sure that if the caregiver has to follow up with appointments, that we are facilitating them to be off and they're being able to go to their appointments. So just supporting them and just circling back around just to be like, you know, how's it doing?
Right.
Often, you know, all the time, employee health was very good about giving us a timely response of what restrictions may be, and then we're ensuring that we're following those, or if they require being off, we just, whatever the situation is for that individual, just trying to make sure that we make sure that things are as convenient
Right.
for them as possible.
Right. Nothing is holding up their FMLA, if you will, or...
Absolutely. and communication, and then that communication to everyone. And I think support to to a caregiver, to anyone, is kind of subjective, what that would be for individuals, but just trying to cue in to some degree on what that individual considers follow-up, what they consider following up with them. Right. It's different for different people.
And knowing your team definitely helps.
That helps a lot.
Yeah. At what point do you help them with the risk and legal? Sometimes frontline caregivers have never dealt with that realm of the organization. Have you helped them in the past? And if you do, how do you facilitate that conversation with the legal risk or even business partners, should it be?
Mm-hmm. So one case comes to mind about another caregiver that had a pretty significant injury. And so I was not present during her initial assault, but after that, she had questions about what she should do as far as who to contact outside of our system, who to contact, and should I see this doctor or should I see that doctor? So I would reach out to individuals in those cases where I could get definitive answers for her and get those questions answered. So it's, I want as little time taken away, of course, from their time at the bedside and their care of other patients. So if I can offset some of that investigative part of that and get them in the right direction, then that's what I should do. Take as much stress off of them as possible.
As leadership demands, right?
Exactly.
Any way you can help to make sure that the next step to them feeling safe and feeling like they can go back to work or what have you is taken care of.
Yeah, I don't think any of us really came into this profession thinking that our safety was an issue. Abby was saying that we are like family. We are like family. We're concerned in the safety and the well-being of the people that we work with. We want the best for our patients, but when one of our caregivers get injured, it's just a little more personal. And you just want to do your best for them.
Absolutely. And I think you said it perfectly, which is this is a rather new phenomenon in healthcare. Dangerous jobs exist. Being a police officer or anything, it's sort of baked in. But in the last 20 years or so, this is a phenomenon that's taken over healthcare. And a lot of us did not expect to go into healthcare worrying about our safety. We are there to take care of patients with respect, courtesy, and competency. You should not be worried if they're going to bite your finger off. But unfortunately, this is the new world that we live in. As people get more and more exposed to different stimulants, drugs, what have you, of all age groups, or there might be an outbreak of a certain, any sort of maleficent intent in the community, these things can sort of become a rather commonplace occurrence. However, the best thing we can do as an organization is to understand the challenges and also equip ourselves proactively against them. And this is one of those conversations that we're doing it in. Thank you for both sharing this amazing vantage points of experience. I would like to wrap up and say that violence affects people everywhere, but it shouldn't appear to be at places of work, especially when it comes to healthcare. We are all in this calling to help and serve our communities and our patients the best way we can, and a safety for ourselves is a big paramount. At Mosaic, we strive to provide that level of safety at every vantage point. Conversations like these help drive that discussion forward, helps us get our, rules and regulations and standards lined up. And Abby, you'll be a nursing leader to the fellow caregivers and the nurses that are coming up into this profession, and your experience will help them shape their perspective. And Stacy, I can't speak enough about your leadership for your caregivers as they look up to you as you help them navigate these unknown things that they weren't trained in nursing school. CPI was not part of my medical training, so I can tell you, but this is the world we live in today. So it is a very brave step you took today, and I hope your voice will encourage others, whether it be with a professional counselor or, like you said, that best friend at work, whether it be your nurse best friend or compatriot, if you will, or your parents, if you will, and these things in aggregate do add up. So I thank you for that, and if you have any questions regarding what the next steps are, please reach out to your leader. Please reach out to HR. Please reach out to Risk and Legal for our listeners out here. They will have chock full of information. Other than that, I hope you all stay safe and keep it a workforce violence-free event going forward. All right. Thank you.
Thanks for joining us for this episode of All the Pieces. Missed a podcast or interested in more information about any of our topics? Visit Connected to access the resources you need to be informed. Interested in having us cover a specific topic or giving us feedback? Send us an email at myepic@mymlc.com. We'd love to hear from you.